This is another study that we published in JCO, one of the big oncology journals, looking at, there are different ways to figure out toxicity and quality of life. One is, and I think the most important, is to ask patients quality of life. The other is graded toxicity. This is typically done by physicians or members of the care team, and so we usually think grade 3 higher toxicity are the significant ones. Everybody's going to have a little grade 1 and a little grade 2. That's expected during these treatments. But so how often is grade 3 or higher happening with chemoradiation? And so in our protocols, we actually set pretty low. I mean, it's 7% grade 3 and nothing higher. Most of it is 6% is GU, 2% is gastrointestinal, GU meaning bladder, GI meaning bowel. So we consider this acceptable and actually low rates of grade 3 or higher toxicity. There are 2 comparative studies. They're a little older. One's from Italy, one's from Sweden, that looked at incontinent diversion versus chemoradiation. The other looked at continent and incontinent diversion versus radiation. And next slide. Long story short, if you were to kind of summarize these quality of life comparisons, this is sort of what they're going to tell you, is that there may be some level of quality of life advantage to chemoradiation over one of those types of surgeries as far as the issues listed here: psychological adjustment, physical well-being, energy, sexual function, urinary function. And there may be equivalence between them as far as social functioning and bowel functioning. Bowel functioning is typically worse with chemoradiation, to be fair. It's actually just in these studies, the rates were higher with chemoradiation versus surgery, but they weren't statistically different. So it's a little bit of, I think if one were to be fair, one would say bowel function is probably more affected by chemoradiation than it is by surgery. But, and here's another question, which actually was given to patients, which is an interesting one. This came from the Erlangen group in Germany, and amongst their patients, they said, if you were to spend the rest of your life with your urinary condition the way it is now, how would you feel about that? And then they gave a number of options. It's a pretty simple question, actually, but very illustrative. And so this is after chemoradiation. And as you can see, most patients were pleased or mostly satisfied or even delighted. It's really a minority of patients that were dissatisfied or unhappy with their quality of life. So this has led to us saying that the best bladder you will ever have is the one you're born with. I mean, obviously this is a slide I use when I'm debating the urologist as to what to do up front. Obviously this is taken with a humorous, but so even if you had some radiation, I mean, if there's an attempt to preserve and if there's interest from the patient to preserve the bladder, I think there are options we can provide. And we feel now that acceptance of chemoradiation in modern bladder-sparing therapy is not really limited by high rates of late pelvic toxicity, and I think I showed you that quality of life data. Next slide. And this is just to show you a little bit of the very honest data from Sloan Kettering, where they did over 1,000 radical cystectomies, and they captured real morbidity data, okay, on a validated scale and all this. Next slide. And this is what they showed, is that about 2/3 of patients had more than one complication of some sort. Okay, 13% were that grade 3 to 5. Remember, that's what I was telling you. Grade 3 or higher, that's kind of significant toxicity. About 1/4 of the patients required a readmission for some reasons, for some complication. And there was a 1 to 2% what we call perioperative or around the time of surgery mortality. So we actually got in touch with the Sloan Kettering group. Can you just click the slide one more time? I'll just highlight something, perhaps one more time. Yeah. So we went to the Sloan Kettering group and we said, can we compare your morbidity data after those cystectomies? And those were cystectomies on what we call virgin bladders. They had never seen radiation. And can we compare those to remember the 30% of patients we do a salvage cystectomy after radiation, right? So here's the question is can you get away with doing a salvage cystectomy after the bladder in that area has seen radiation? And how does that compare to never having seen radiation, right? So that's what we try to do. And again, if you look at grade 3 or higher, which is the red box, our data which is on the left within the red box, versus slung tethering,